Welcome, and this title of my talk is a misnomer. It's our favorite neutrophil. And what I'm going to be talking about to introduce you to the beloved neutrophil is some of its development and function. And I have just a wonderful set of slides demonstrating its function and movement and its ability to kill bacteria. And we're going to talk about some of the neutropenic disorders. So we're going to start out, this is probably one of the most complex slides, but what I want to really demonstrate for you, myelopoiesis refers to the development of neutrophils within the bone marrow. And we start off with a primitive cell called a stem cell, and then with endogenous growth factors present within the marrow, then progenitor cells through the use of, you can't see it here, GCSF will develop into neutrophils, which I'll be talking about this morning, and then there's a growth factor that allows for the development of monocytes. Let's move on. So the production and kinetics of neutrophils briefly are illustrated in this slide. The first recognizable cell that gives rise to neutrophils in the bone marrow is called a myeloblast, and it develops then into a promyelocyte, which is arrested in severe congenital neutropenia. This cell fails to develop into these later stages that give rise to the neutrophil. And as you can see, it takes about 10 days to get a mature neutrophil within the bone marrow. The neutrophils, or segmented polymorphonuclear leukocytes, then go into the bloodstream, and 50% circulate in the blood and 50% adhere to the lining of the blood vessels. And then I'll show you that the neutrophils then migrate into tissue where they are thought to survive up to a period of 3 days. So when we give Neupogen or GCSF, it shortens the period of cell division and maturation to really a matter of a few days. And the neutrophils, after the primitive cells, after being exposed to GCSF, have accelerated division and maturation, and within about 5 days, not the typical 10 days, are able to be released into the circulation, into the bloodstream. So I have some pictures of these developing cells. This is a myeloblast, and the next set of slides are taken from a wonderful atlas by Marshall Lishman, and we go from that particular cell. Here's a promyelocyte, which I said is the dominant cell that we see in severe congenital neutropenia and fails to divide and mature. Here's another picture of a myeloblast. And you can see here, begin to appreciate that it's starting to develop granules. This cell is called a metamyelocyte, and here's our band. So the band, like the neutrophil, is capable of ingesting bacteria, and here we have the segmented neutrophil, the star of our show. So briefly, to discuss cell function, and the next couple of slides are taken from the work of Tom Coates. We see the neutrophil lining the cells of the blood vessel and then migrating into the tissue where they're capable of ingesting bacteria. We can divide the function of the neutrophil in multiple stages. And we've talked about the ability to mobilize neutrophils, and they're attracted by chemical signals to bacteria. They recognize the bugs, ingest them, and then two very important steps, those granules that I pointed out in the promyelocyte play a role in depositing proteins that degrade, or enzymes that degrade proteins on bacteria, and then reactive chemical species are involved in killing of bacteria. So this is one of my own slides that demonstrates then the egress of neutrophils from the bone marrow into the blood vessel stream again. And here you see the neutrophils rolling on the blood vessel wall, then moving between these cells on into tissue where they ingest bacteria and then eventually undergo cell death and are removed from the tissues by cells known as macrophages. So here we see a transmission electron micrograph with the neutrophil having ingested a yeast particle and granule constituents being deposited into what is called the phagosome. So when the neutrophil sees a bug, it extends arms, if you will, called pseudopods, and then withdraws the bacteria into this cavity here. And here you see in a matter of seconds that the neutrophil has ingested some particles, and you can see that the granule constituents, as indicated here, are deposited again into the phagosome and are involved in killing the ingested bacteria. And this occurs over a period of just a few seconds. So what are some of the infectious complications that we see in disorders of the neutrophil, either due to neutropenia or functional defects? Well, with severe neutropenia, we see frequent or unusually severe bacterial fungal infection that can affect the skin, lymph nodes, and lungs, or cause infection in the liver. Brain abscesses, on the other hand, are very unusual with chronic neutropenia, but are seen in some of the disorders of phagocytosis, the functional disorders. Many of you are well aware that with severe neutropenia, we can get inflammation of the gums, or those painful mouth ulcers or tongue ulcers. And then there are a number of bacteria that are involved when we have severe neutropenia in mediating all these devastating effects. So neutropenia, this is very important, is defined as a decrease in the absolute number of circulating segmented neutrophils and bands in the blood. Obtaining a complete blood count with a differential count identifies this condition. That is, we pay particular attention to the percentage of segmented neutrophils and bands. This determines the absolute neutrophil count, or ANC, which is determined by multiplying the total white blood cell count by the percentage of segmented and band forms. The ANC for the general population, that is adults, ranges between 1,500 and 8,000. So neutropenia defines a reduction in the absolute neutrophil count below the norms for age and ethnic groups in the blood circulation. It's age-related in pediatrics. So a term newborn over 1 week has an ANC just over 1,500 or greater. And an infant from 1 month to 4 years is defined as having neutropenia if the counts are under 1,000. A child, adolescent, and an adult under 1,500. And then we see in about 1/3 of African Americans that their absolute neutrophil count can be as low as 800, but it's physiologic for them, no disease. And if somebody wants me to discuss that further, I'll tell you why, but it's a fantastic story. Okay, so here I have a slide of a segmented neutrophil. Here's a lymphocyte, another lymphocyte, and another segmented neutrophil, and this is a monocyte. So the monocyte is capable of ingesting bugs, but it's a sluggish cell. You know, if we're going to conquer a bacterial infection, it has to take place within 2 hours of invasion of those bugs. And the neutrophil is the dominant cell that is capable of responding to a bacterial infection. On the other hand, the monocyte takes about 12 hours to get to the site of inflammation. The monocyte primarily serves as a scavenger cell, ingesting neutrophils that have spent their wares. The monocyte in turn gives rise to what's called tissue macrophages in the spleen and in the liver and in the lung. And these tissues play a role in clearing bacteria from the bloodstream. So one of the dangers, say with neutropenia, if you remove the spleen, it predisposes the patient to much more serious infections. Okay, here you see an eosinophil that is elevated in patients with allergic disease. So, suspicion of neutropenia. If you have a patient with acute severe bacterial infections, a history of recurrent infections, prolonged or elevated temperatures over 101 degrees Fahrenheit, or a series of infections, pneumonia, peritonitis, the lining of the abdomen, GU, urinary tract infections, buccal and tongue ulcers, chronic inflammation of the gums, skin infections, and perirectal infections, you have to be suspicious of neutropenia. Now, more commonly, we find neutropenia associated with malignancies, and especially after giving cancer chemotherapy. We're seeing it with immunodeficiency syndrome, where the lymphocytes aren't working properly, and acute neutropenia occurs commonly with viral infections, but it's very self-limited, or drug exposure. And this is more a problem in elderly adults rather than children, the adults being on multiple drugs. So the clinical risk assessment, we have no problem if the absolute neutrophil count ranges between 1,000 to 1,500. Moderate problems if the counts range between 500 to 1,000. And then we talk about severe neutropenia if the counts range between 300 to 500, and very severe if under 300. So the clinical risk assessment, we divide neutropenia into acute versus chronic, lasting more than 3 months, with ANCs and absolute neutrophil typically at several times during that 3 months being documented to be under 500. And most importantly, can neutrophils be mobilized from the bone marrow? So with congenital, cyclic, and many forms of idiopathic neutropenia, we have problems in producing sufficient neutrophils. On the other hand, with immune neutropenias, where the neutrophils are produced but are destroyed by antibodies in the circulation, patients typically have less serious problems with infection. So acute neutropenia occurs frequently. Congenital neutropenia is rare, about 2 per million. And this is based on French data. Cyclic neutropenia, even rarer, about 0.6 per million. So you can understand most physicians are never going to see these types of neutropenias in their career. We estimate maybe the idiopathic neutropenia in adults that probably there's somewhere around 10 to 15,000 adults throughout the country that are impacted with idiopathic neutropenia. So the physical exam of patients with neutropenia, we look at height and weight, because kids with chronic infection have trouble growing. A detailed exam of the oral cavity, and we get our dentist involved. Skeletal abnormalities that are seen with the Shwachman-Diamond syndrome. And then with some of the bone marrow failure syndromes, we have problems with pigmentation, dystrophic nails, warts, eczema, and skin infection, and some rare disorders of congenital neutropenia are associated with cardiac and blood vessel abnormalities. And we pay particular attention to lymph node enlargement and enlargement of the liver and spleen that more commonly are associated with malignancies. So the laboratory exam of neutropenia, obviously we need a CBC and a look at the blood smear that you saw. And if the neutropenia is recurrent, my friend Dr. Dale taught us so well that we need to get blood counts 3 times a week for 6 weeks in order to document the possibility of cyclic neutropenia. Coombs test goes along with a patient who might have autoimmune disease, and this refers to antibodies against red cells. And we pay attention to antibody levels, and in patients who we think might have a cellular immune defect, or we look at lymphocyte subsets, anti-neutrophil antibodies I'll talk about later, but with immune neutropenia, obtaining those probably is not that important, and I'll show you some data. And then if we're really going to pursue this, kids who might have certain viral infections associated with acute neutropenia, we can test for the various viruses by obtaining specific antibodies. And the most important thing is the bone marrow exam and chromosome analysis that we obtain in all patients with chronic neutropenia. Okay, on the neutrophil, we have specific proteins that are unique to the neutrophil, and it's not important to know these, but when patients develop immune neutropenia, the antibodies react to one of these proteins specific to the neutrophil. So let's talk about immune neutropenia of infancy. This is probably the most common referral that I see in my practice. It occurs 5 to 10 symptomatic cases per 100,000 children, and the age distribution is 5 to 15 months. So typically we see in young children that they have antecedent history of an ear infection or a viral infection, and then they become acutely neutropenic and make antibodies against their own neutrophils. 80% of these children suffer from mild infection. That is skin, ear infections, upper respiratory tract infection. And we see the same process in normal kids. So actually, these children do very well. The other 20% have a lot of recurrent fevers and more serious pneumonias, and those are the ones that I'll put on Neupogen. The laboratory indicates an absolute neutrophil count from zip to 1,500. The bone marrow is usually normal. The morphology, there's full development of the precursors into neutrophils. I talked about the presence of specific antibodies, and the neutropenia resolves spontaneously after a median of 17 months. So in most children, by 4 months, or 4 years, I'm sorry, the neutropenia will spontaneously disappear and patients fully recover. This is what published in the literature, and with Adriana's help, we're looking at data from our own registry to see if that observation is valid, or if some children it takes up to age 5 to 7 years before they fully recover. Okay, so here's some data from our own registry, and we looked at patients who were documented to have specific anti-neutrophil antibodies, and in the same age group, those that did not have antibodies. And basically what this slide demonstrates that the age of onset is the same in these two groups, and the age of recovery is 3 years in those with the antibodies, 4 years in those that had no antibodies demonstrated, but these values were not statistically different. Basically, the antibody testing is very difficult to do. If you do it just once, only about 70% of children will be documented to have an antibody. If you do it 3 times, maybe 95%. The antibodies don't bind very well to neutrophils. So, and there are only a couple of very good labs in the country that are capable of doing good testing. But as you can see, there's no difference in those that were tested to be antibody negative in this age group versus those that were positive. So I think, getting an antibody test that's positive is reassuring for the parents and the referring physician, but it really isn't all that helpful. And if you don't do it, if the child's in the right age group, it's likely that child is going to recover. So the management of children with immune neutropenia of infancy, most important to give vaccinations, including live vaccines. These children lymphocyte function that determine the ability to make antibodies is perfectly normal. Many of these children do not require Neupogen. A bone marrow, if you were in practice, may not be necessary to go on the registry. We have to do one, but the bone marrow usually is normal. And basically, these children can be managed at home by giving drugs such as Motrin or Tylenol, and to reduce fever. If the fever continues to increase above 103 degrees, then the patient needs to go to the hospital and get blood cultures and put on broad spectrum antibiotics. But that's unusual. I tell parents, please manage your child at home and don't bother taking the child to the hospital, to the ER, or contacting the local physician and hospitalizing the child, because it's just difficult for the child and for the parents, and nothing's really accomplished. Okay, there are other autoimmune neutropenias, one associated with lupus, and then some associated with the immunodeficiencies, including, I think, Dr. Newberger's managing a child with so-called hyper-IgM syndrome. And we're not going to discuss treatment here. So let's move on to severe chronic neutropenias. This is a heterogeneous group of disorders of neutrophil production associated with impaired production of neutrophils and recurrent bacterial infections. And the severity of the disease is related to the degree of neutropenia. There are three main subtypes of severe chronic neutropenia: idiopathic, cyclic, and congenital. And here you see the typical painful tongue ulcers and a skin infection and inflammation of the gums. Oh boy, this can be just so painful, and if untreated, this patient will lose his or her teeth, because the neutrophil plays a key role in preventing the invasion of bacteria into the soft tissues of the gums and lining of the cheeks. So severe congenital neutropenia, it has an early childhood onset. I've made the diagnosis even at birth. The bone marrow shows a maturation arrest at their promyelocyte that I pointed out to you. And these patients in the past, before Neupogen, had recurrent life-threatening bacterial infections. In fact, when this was originally described by Kosman, a military pediatrician in Sweden in the 1950s, he looked at an inbred group of Swedish children, and the 90% died in infancy of recurrent pulmonary infection. And Dr. Dale and others showed that the severe congenital neutropenia is associated with an enzyme found in the granules of neutrophils. That's the elastase enzyme. So the elastase is found in the neutrophils, and mutations of this enzyme is associated with severe congenital neutropenia, primarily seen in the United States, and it's inherited in an autosomal dominant fashion. That is, 50% of children have the risk of passing it on to the next generation. So 10 to 30% of patients with severe congenital neutropenia can evolve into acute myelogenous leukemia, and treatment is stem cell bone marrow transplantation. And there is a need for annual bone marrow to survey for chromosome abnormalities seen in these patients if they're progressing toward leukemia. And the patients remain at risk for infection, even if they're successfully treated to restore the neutrophil count in some patients, because some of these children have impaired neutrophil function. And then we have a very complicated classification of other causes of neutropenia. Dr. Shimamura is our local expert on a disorder called Shwachman-Diamond syndrome that is associated with malabsorption in the gut and neutropenia that can progress into aplastic anemia or leukemia. Cyclic neutropenia, Dr. Dale's favorite. It's the autosomal dominant disorder, and it has been linked to mutations in that same enzyme elastase in the neutrophils. And it's found in around over 90% of patients with cyclic neutropenia. But most importantly, it is not associated with an increased risk for leukemia. So cyclic neutropenia is dominantly inherited. Cycle typically lasts for 21 days and is associated with 4 to 6 days of profound neutropenia. And the marrow during neutropenia shows a myelocyte arrest, and it's due to a stem cell regulatory defect. So here in this slide, what I have, this is the absolute monocyte count in a patient with congenital neutropenia and the profound lowering of the absolute neutrophil count. And what I wanted to point out to you, there's no relationship between the level of the monocyte count and the absolute neutropenia, whereas in cyclic neutropenia, we see at the nadir of at the lowest point of the absolute neutrophil count, there's relationship here in blue with the absolute monocyte count that's elevated. So this is useful not only for deciphering and recognize the difference between cyclic and congenital, but idiopathic neutropenia as well, because there's no relationship between the monocyte count and the lower neutrophil count. And many physicians will obtain just the absolute neutrophil count and document neutropenia, but fail to obtain a monocyte count. So my last slide, and I think we were represented with a lot of patients with adult idiopathic neutropenia. This includes idiopathic and primary autoimmune neutropenia. That is to say, adults who don't have autoimmune disease associated with any other disorder, say rheumatoid arthritis. We have a normal bone marrow and chromosome analysis. It occurs primarily in females. About 78% of patients with idiopathic neutropenia are women, and the management may not require the use of G-CSF or Neupogen if the patients are having little in the way of symptomatology. But it's been my experience that in adults, very few of these patients have full recovery of their absolute neutrophils count over time. And with that, I'll conclude and thank you. Do we have time for any questions, Dave?
Oh, questions. Okay.
Okay.